Here I'll be talking about TAP, evidence and essential steps. The learning points for this talk is to understand the origin and evidence of the TAP technique, to learn TAP technique step by step, and to learn converting TAP to crush or culotte if needed. Now, what is TAP? TAP stands for T and protrusion. It is a modification of provisional T stenting to optimize bailout side branch stent implantation. By doing TAP, you can ensure full ostium DES coverage and you can maintain a final kissing inflation and you may optimize with a final port in the end. The origins of TAP, it started by two independent groups in Italy and South Korea in the early DES era, and the full description of technique and clinical experience was actually reported back in 2007. It is essentially a modification of a T stenting technique. It was aimed at optimizing bailout stent implantation in provisional cases, and finally, as the years goes by, it was accepted as part of bifurcation strategies for PCI. In terms of evidence, there were no large randomized trials with long-term outcome data for TAP procedure. It was first mentioned by Bozota in 2007 along with Antonio Colombo, where they had this pilot study with two independent series of patients. And then there was Al-Rashdan in 2009 looking into a patient series with a TAP procedure. Bozota again in 2009 doing it as a bailout strategy with a patient series. Naganuma in 2013 looking into retrospective data. Artemis in 2014 was a bailout strategy study. And Zavik in 2014 looking at bioresorbable scaffold with low pressure final kissing using a TP technique. So this shows all this data that has been available for the TAP stenting, like I've mentioned before. If you look into the first study by Buzeta, it was looking into a 73 patient data with a 37% unprotected left main, whereby there was 66% with Medina 111 and follow up for 9 months with the result of a 6.8% target vessel revascularization and 1.4% definite stent thrombosis. Considering this was done with the early DES era, I think this was a good result despite the complexity of the procedure, and that was followed by the other authors as you can see in this chart. So having a slightly lowish TBR of less than 10% and a low stent thrombosis rate, so it has been accepted as one of the important techniques in bifurcation stenting. So what are the steps? Yeah, if you can see here on the picture on the left, you have a main vessel stent that has been deployed, and then subsequently you will perform a kissing technique to open up the side branch, and then after putting another stent in the side branch, ensure that the all the ostium is well covered by DS, leaving no geographical miss, and subsequently you can pull back the stent the balloon from the stent into the main vessel to proceed with the final kissing. And on the side picture on the right side, it shows how it looks like with this neocarina here between the main branch and the side branch, and this is the only thing that might cause problems, but if you have a good kissing, this will be very minimal. So the steps would be a main vessel stand implantation at first, rewiring of a side branch, and if you could, try to use the most distal strut using a pullback rewiring technique, and then subsequently you'll do a kissing balloon at the main vessel and the side branch, and subsequently you will put in a side branch stand with intentional minimal protrusion into the main vessel, and then with an uninflated balloon in the main vessel across the side branch takeoff, deploy the side branch stand, do the final kissing inflation with the main vessel balloon and the side branch balloon. And if you want a good result, you should use the NC balloon kissing, because sometimes you can have suboptimal stand expansion, and you can finish off with a pot if necessary. Now, this is the impact of pre-tap kissing balloon. What we need to do to ensure that the strut of the main vessel opens well, it is advisable to try to use a distal strut, because if you use a distal strut, the chances of you having a lot of neocarina would be much less. If you can see here in this C panel, you can see that the side branch stand is jutting out a lot more compared to this side branch at the panel F. So by doing a distal rewiring technique, you may be able to avoid too much of neocarina in the main vessel. Now, what's interesting about TAP is that you can convert it into crush and cool out. So you do not have to worry too much if something happens. Let's say you cause some geographical miss over here. You can still extend with another stand and make it into a crush or a cool out. So that is one technique that which give you assurance on handling problems if you have that during the intervention of this bifurcation. The main strength of a TAP technique, it is simple. It can be done using a 6 French guiding compatible catheter. It can have a full coverage of the side branch ostium with no geographical miss. It facilitates the final kissing balloon inflation. It is useful for bailout situations, and like I mentioned earlier, you may convert it into a crush or a cool-out technique if the TAP is not perfect. The drawbacks of a TAP technique is that it creates a single layer stand strut neocarina of variable length. So therefore, you have to make sure that the side branch stand touches the main vessel stand with a minimum overlap to prevent such a long neocarina later on. It may not be easy if the side branch is diseased and it is not prepared earlier, especially if there is calcification. And optimum side branch ostium dilatation is a critical issue because it might cause as a site of a post-procedure minimal stand area and large neo-intimal formation. So in summary, ladies and gentlemen, TAP has been established with good outcome, although there was no large randomized trials with long-term outcome data for reference. TAP technique is simple and allows provisional stenting to be performed first using a 6 French guiding catheter, and it is applicable for many bifurcation anatomy. However, the operator needs to understand the challenges based on other factors such as calcification, lesion preparation, and wiring skills. Thank you very much for your attention.